our online audience and our in-house audience. I welcome you all to this 57th ECO session, and it's our 50th session, ECO session this year. And the topic today, we are going to be looking at severe malaria. It's very crucial to us, as you know, that Uganda is one of the countries that are affected with malaria. I believe that all of us in lifetime, we've ever suffered from malaria. So each household in our nation has been affected by malaria. So this topic today is crucial to us to know the presentation, the management, the things that we can do to prevent and how do we manage complications. So in house today, we are having a team of experts, and they are going to be introducing themselves to us. And we have our case presenter who is joining on to us online, and our online audience. So we are going to be starting with self-introduction. And today's modulator, my name is Kwagala Racheal. I'm an emergency SHO year 2 from Makerere University. So I'm going to allow the team of experts that we have in-house to self-introduce themselves, and we're going to start with the extreme person seated on the extreme left, and then we shall go anti-clockwise. So, Sister Lucy, I welcome you to introduce yourself to us.
Thank you very much, moderator. I'm by the name Lucy Aparo, and that's from Gulu RRH.
Okay, thank you so much, Sister Lucy.
Thank you very much, moderator. Good afternoon, everyone. My name is Wamala David. I'm from Mulago National Referral Hospital, and I'm stationed in the medical emergency unit. Thank you.
Good afternoon, everybody. Thank you, moderator. My names are Doreen Okong, Alaleit. I'm an emergency physician, and I'm also the current president of the Emergency Care Society of Uganda, and I'm also a mother of 4 boys.
Wow, wow. Wow, wow. We have the president in the house as one of our experts today, and that's a great honor to us. So at this time, we're going to have our online experts to introduce themselves. The person who is going to do this presentation.
Good afternoon, everyone.
Dr. Ronald, you can please unmute.
Yeah, I hope I'm audible. This is Dr. Ronald Ameny, an intern doctor currently stationed at Bwera General Hospital, and I'm the case presenter for today. I'm really glad to be part of the team. Thank you.
Thank you so much. So at this time, I know we are so excited for this session. As my tutor already said, who is excited? I personally am so excited to learn, to get wisdom today from this session. So I know I'm seeing very many people who have logged on to this call today, but you can continue to share the link. Please get your phone and share that link widely, and maybe you can call a colleague who hasn't yet joined. You can tell them to join. And at this time, I know our online audience, you have a lot of expectations, things that you want to learn. So as we are picking that, we are going to have a pre-test. The pre-test is to know some of the things. It's not what can I say? It's not an exam, but to check our knowledge and the effect of this session. So you can go on as you can see the poll is already posted onto the screen. So you can go ahead to answer those few questions, and then we shall straight away dive into today's session. Meanwhile, for people who have not given us their expectation when they are registering online, at this time you can feel free to unmute and or raise up your hand, and we shall pick on you to tell us what do you expect. How is malaria affecting you? You might be in Zulu, you might be in Soroti, you might be in Ginger. So we would love to hear the online audience that we are having today for this session. So you can put up your hand while you're filling the poll and tell us some of your expectations or things that you want us not to miss out. I know our experts have prepared a lot for us, but might be that one thing maybe they input, and if you share it out, we'll include in our talk today. Thank you. Anybody? Anybody who wants to tell us their expectation?
Yeah, I think the expectations have been already captured in the registration page. So do we need to repeat the expectations?
Yes, thank you so much, Abraham. Yes, I know people have talked about the expectation, but I was adding that if there is something maybe you feel like should be, maybe you did include in the expectations while you're registering, you can share it out. Or it could be the experience of malaria in any hospital, any facility where you are having this session from. How do you manage malaria? What has been the challenges? Maybe you can give us a brief during this session, because this session is not going to take long. This period of poll is not going to take very long. But at this time, you can give us maybe an experience. What was that case that was complicated to you and you failed to manage very well? That was malaria, or you managed very well? Yes. Anybody online?
Yes, thank you so much. My name is Patience. I'm wondering also whether we are going to discuss about the management of malaria in pregnant mothers. Thank you.
Okay. Thank you so much, Patience. I can see your concern. Malaria in the special groups, and our experts are going to tell us about that. I can see another hand. Moses? Moses, can you go ahead?
Yes. Thank you so much, the panelists. Recently, I think 1 or 2 years ago, WHO rolled out malaria vaccine, which we know is being utilized in other countries. Wanted to know, for Uganda, has this vaccine been rolled out already? What's its impact on the severity of malaria? For example, if there are some studies currently, for the Ugandan population, for example, children immunized or who have been vaccinated with this malaria vaccine, what's their impact or what's their query with malaria? Does it prevent or reduce the risks of severe malaria? And if this vaccine is rolled, and how can we get it, or how can we be able to administer it to our patients? Access to the vaccine. Thank you so much. I probably talked much.
Yeah, thank you so much, Moses, and all that has been captured. I'm going to give a chance to more two people. I can see Godfrey. Godfrey, your hand is up. You can go ahead.
Thank you very much. My name is Godfrey Natseli. I'm a fifth-year medical student at Makerere University. I was interested in the management of cerebral malaria in adults, especially when it's presenting acutely. Thank you very much.
Oh, thank you so much. And I think that is one of the complications of malaria. Ruth Atkunda.
Oh, thank you so much. Maybe issues around asymptomatic treatment for malaria, especially when it comes to negative labs and the implication. Thank you.
Thank you so much, Ruth. It has been captured, like when would you choose to treat when you have a negative result? And by experience, was it last month where someone went to the clinic and had the symptoms of malaria, then they did a BS, nothing was captured, went back again, came back 3 times and they were testing and they were not getting malaria and it was on the food. So the question was, where was the problem? Was it the lab? Was it that the lab technologies? Was it malaria hiding where? So those are challenges, but we are blessed, our experts are going to talk about all that. Thank you so much, Akunda. So I think now we are all done. We are going to close the session of the pre-test now, and we are going to go straight into our to deep dive into this session today. And we are going to have a patient case presentation, and we'll have a few reaction. Then we'll have another session. So I welcome Dr. Ronald to please go ahead and present to us the case.
Good afternoon, everyone. This is Dr. Ronald Ameny, an intern doctor at Bwera General Hospital, and I'm going to be taking you through one of the cases of malaria that we managed at the facility about 3 weeks ago. This is a case of BI, an 18-year-old female who was brought from home around 10 p.m. in the night with a history of 2 episodes of convulsions from home, and had also had high-grade fevers for about 3 days. However, at the time of admission, this patient was unconscious. So we received the patient at the emergency unit, and we went ahead to do our emergency assessment of this patient. And when the patient came in, they had features of difficulty in breathing and was snoring audibly. So when we checked the airway, we noted there were no foreign bodies, and the cervical spine had any fracture of any sort. However, because of the inability of the patient to support the neck, we had to insert an oral airway device, the Guedel's airway, to keep the airway patterned. And then we went ahead to assess the breathing of our patient. We noted she was tachypneic at 34 breaths per minute and was saturating at 87% on room air with widely audible basal crackles on both the left and the right lower lung lobes. So as our emergency management, we had to put this patient on oxygen by nasoprongs. Initially it was stable, but saturation was at 94%. But later, the saturation started dropping to 90 and below. So we had to switch the patient to an oxygen mask. So because of the widely audible basal crackles, we also had to elevate the bed in a cardiac position. Then when we checked the patient's saturation, we noted that our patient was tachycardic with a pulse rate of 144. And this pulse was very fast, that is the bounding nature, and also we noted it was of weak volume. Then we also noted our capillary refill was more than 2 seconds with cold extremities. However, one thing you should note with this patient is that on that day, on that Friday, it had rained, and as we shall go ahead, we shall see the circumstances that happened before the admission. We also noted the blood pressure that was measured was 86/53, and the patient was severely pale with heart sounds 1 and 2, with an added heart sound 3. So as our emergency management, we had to insert 2 large bore cannulas of gauge 18, and we had to resuscitate with IV fluids, normal saline and D5. Then we also took off a blood sample for blood grouping and cross-match. Sorry, there was a mistake here. The patient was blood group B positive. However, that very night, we couldn't get the blood group B positive at the facility. So we had to connect with a neighboring facility to acquire the blood. Then we also noted in the disability, our patient had reduced GCS of 8/15. However, pupils were equal and reactive to light with normal tendon reflexes. The neck was stiff, however, on eliciting, trying to elicit the Cunnings and the Bradzinski, there was no response. So we also checked our sugar level, and we noted patient was severely hypoglycemic with blood sugar of 1.7 millimoles. So we had to give IVD50, 30 mils once, and also put the patient in lateral recumbent position. So on exposing the patient, we noted that there were no areas of trauma on the body. However, the patient was cold and muddy, and the axillary temperature we noted was 35.5. So we had to remove all the wet clothes and ensure that the patient was covered in warm clothes. So after stabilizing our patient, we went ahead to do our sample history, whereby we noted the patient had 2 episodes of generalized tonic-clonic convulsions that started from home and was associated with urine and stool incontinence. The family reported that after the first episode, the patient recovered, but in the second one, the patient lost consciousness. That's when they decided to bring the patient to the facility. They had also noted that earlier in the day, she had been complaining of generalized body weakness with associated dizziness, and they noted that she had very poor appetite. And all these were climaxed by symptoms that had worsened that evening with the convulsions. So they also told us that 4 days prior to admitting this patient, she had been taken to a clinic where after she had complained of headaches that had been persistent for 3 days and was associated with on and off high-grade fevers with episodes of vomiting. So from the clinic, they just did an MRDT and it turned out positive, and they started this patient on coartem. So she picked up a bit. However, when she felt better, she stopped taking the medicine. So we noted our patient had no history of any food or drug allergies, and the only medicines they had been at from home or the clinic was coartem and paracetamol. So in the past medical history, we noted this same patient had been managed for severe malaria about 1 year ago. And we noted also that the patient had last eaten in the morning. That was about 11 hours prior to the time of admission, and had taken only tea and cassava. So in the events that led to bringing this patient to the facility, they noted that the first episode of the convulsion had occurred outside while the patient had gone to remove some clothes. So it was raining then, and the patient fell in the muddy soil in the compound. So in our problem list, by the time we admitted this patient, was not convulsing, but in the admission room, in the emergency unit, the patient had 1 episode of convulsion. We also noted that much as the patient had history of high-grade fevers, the patient was very cold at the time of admission. Then we also noted throughout the day, the patient had barely eaten anything and was unconscious, so couldn't eat. They had also given us the history of the tea-colored urine. And we also noted that when we assessed the patient, we were having a rapid pulse of weak volume. So we were suspecting a circulatory collapse. Then because of the features of difficulty in breathing, we thought about malaria-related acute respiratory distress syndrome, possibly because of either pulmonary edema or the patient could have aspirated in the course of the convulsion. So here is a highlight of the CBC that we had done that evening. Not that we had first done a hemoQ before doing the CBC. The CBC came after, and as you can see, our hemoglobin was reduced and our platelet count was very reduced. However, this patient had no bleeding of any sort coming from any part of the body. Then also blood group B plus was out of stock at the facility that night. So we ended up transfusing the patient the next day in the morning after securing the blood. So the investigations we did in the emergency room, we had to do a random blood sugar. And we noted that our sugar level was 1.7 millimoles per liter. MRDT still was positive, and the sample taken for blood smear in the lab was having BS of 2 pluses. They didn't give us the parasite count per high power field. We also did hemoQ, and we noted HB was 4.9. However, our CBC brought, the CBC that came later on had those parameters that we highlighted earlier. Our patient was blood group B positive, which we didn't have at the facility at the moment. And because it was nighttime, we were unable to do a lumbar puncture because the samples wouldn't be processed. So we also went ahead to do a urine dipstick where we noted that all other parameters were okay, but the patient had hemolyzed trace red cells in the urine. Then LFTs, RFTs, and serum electrolytes were not done because of issues regarding reagents were not available. So in our diagnosis, these were the possible things we were thinking of with our history and the investigations we did. The first thing that came to our mind was severe malaria with possible cerebral involvement. And we also noted that there was a severe hypoglycemia. Our patient was very pale, so there was also severe anemia. And we also noted that because of the tea-colored urine with hemolyzed trace cells in urine, our patient had features of AKI. And because of the nature of our 3D pulse, that was bounding, and we were suspecting that our patient had a shock. The other thing we should have ruled out was meningitis. However, even in the course of the day, on the first day of admission, the patient was still too unstable for us to do a lumbar puncture. So as part of our management, we went ahead to initiate this 55 kilogram patient on IV artesunate, 132 milligrams. So we gave the first dose. However, with the first dose and sufficient IV fluid hydration, the urine still remained tea-colored. So we went on to give a second dose. Then, as we were finishing the second dose, there was a great improvement in the patient. So when we did a post-artesunate BS, it was negative. However, the patient was still weak and was barely eating, so we continued with IV artesunate, 132 milligrams once a day for 2 days till the patient was able to eat. That's when we switched to dihydrated artemisinin and piperaquine for 3 days before discharge. So in the part of our supportive management that we did throughout the stay in the hospital, we noted that since the patient convulsed once in the emergency room, we had to act fast on the convulsion. So we gave IV diazepam 10 milligrams twice in the first hour, because we gave the first one, then the convulsion reoccurred, then we gave the second one. When the patient convulsed the third time on ward, we had to give IV phenytoin. It was what was available. We gave at 15 milligrams per kilogram as a loading dose. The patient didn't convulse thereafter going forward. Then also in the course of the night, much as we received the patient when they were hypothermic, the patient started spiking fevers late in the night. So we had to give IV paracetamol for 3 days. And then, as we noted earlier, we had supported our saturation with oxygen by nasal prongs before switching to oxygen mask. Then because our patient was very hypoglycemic, we had to give D50, 30 mils. Then we went ahead to insert an NG tube, and feeding was by NG tube. We also noted the patient lips were dry and cracked, so we had to offer oral hygiene for the patient. So the next day we had the red blood cells. We had packed red blood cells. So we went ahead to give 10 mils per kilogram, with also IV furosemide to support to try to challenge the kidneys alongside the fluids, as well as to help us with the features of pulmonary edema that we had. So we also had to give, we also had to insert a urinary catheter to monitor our urine output and see if the urine was clearing. Then we also supported the patient with IV fluids. However, we had to do it cautiously because we didn't want to cause hemodilution before giving this patient blood. So in the follow-up, we managed this patient for about 6 days in the facility. And we noted that the patient kept on improving, as noted by the GCS that we kept on monitoring, as well as the urine output. Then the patient had started eating fairly well on the 20th. That's when we started the oral medications on the 21st, when the patient was able to walk. Then our repeat blood smear for malaria parasites were negative. So also you should note that we didn't know the HB of this patient prior to admission, and they come from an area that is close to a water body. So we also had to discharge them with a mosquito net, and she had reported not being dewormed for the past 5 years, so we had to deworm. And also we had to educate them on their nutritional habits to help her recover faster. Thank you very much. This was the case we had managed.
Presentation, been elaborate. Thank you so much for managing these patients, and you had good outcomes. So you have very many questions I can see on the chat that some members want clarity on. Someone was asking that you talked about a patient having tachycardia, but what was the character of the pulse?
So in the presentation, we noted, I think maybe the person missed that part. We said that our pulse was bounding and it was thready, much as the rate was regular, but it was just bounding and very thready. Yeah.
Yeah, then maybe another thing, you say that there was no issue of trauma, but the patient started convulsing after a falling into mud when he had gone out to pick clothes. Was that so?
Yeah, the patient had, they said it was a soft ground, so the patient had fallen.
Oh, so she had sleep. And then one more last thing, other things will be handled by the team that is answering online. Yeah, someone was asking, why did you give packed cell with basics?
The reason we gave packed cells with Lasix is, first of all, we already had features of pulmonary edema in our patient. So because we were giving up to 550 mils over 4 hours, we wanted to ensure that we didn't overload our patient because we suspected that the kidneys were already not doing well.
Thank you so much, Dr. Ronald. I think for the rest of the questions, they are going to be answered on our expert on online, who's in charge of questions online. So at this time, we're going to go straight to another session. We are going to have our experts that are in-house. And our first session presentation is going to be emergency presentation. So of this severe malaria, how will a patient present in emergency, thinking you're in ED as Dr. Ronald was, how will a patient present? So we are going to have that, and our presenter is Dr. Doreen, the president. Welcome.
Thank you. I think before I dive into the presentation, I just want us to get familiar with the epidemiology of malaria, especially in our country. So according to the WHO guidelines and standards of 2022, globally, about 250 million cases of malaria were recorded globally. And they recorded about 600,000 deaths. Majority of these cases were from Africa. And in Uganda, we're looking at about an incident rate of about 470 cases per 1,000 people, and approximately 70,000 to 100,000 deaths per year. Unfortunately, majority of those deaths are due to children under the age of 5. That already tells you the burden of malaria, not only in Uganda, but globally. Actually, in 2021, Uganda was ranked the third most biggest contributor of malaria cases worldwide. So we are living in a malaria endemic zone. So it's very important that we're having this kind of discussion, because I believe based on where we stay in the tropics, we suffer with malaria a lot. Now, in terms of the emergency presentation of malaria, I'm going to make it as basic as possible, and I'm going to simplify it using the ABCDE. In the practice of emergency medicine, the ABCD is very, it helps you assess your patient in a very systematic way. So in your airway, a patient will come in and they could have an airway problem. So it means the airway is obstructed. So they could be either snoring, like this patient that we saw in the case. They could be snoring for a couple of reasons. One, they could have altered mental status, either from hypoglycemia or cerebral malaria. And the snoring comes about because the tongue has fallen back into the airway. If you look into the airway, the patient could have secretions, they could have vomits, and this is also going to obstruct the airway. So all these airway issues can push you to hypoxia, which then feeds into a breathing problem. So in terms of breathing, when you look at your patient will be in respiratory distress. So they'll be breathing very fast. They could be using accessory muscles. They could have intercostal recessions. And when you look at your patient is struggling to breathe. They could have acidotic breathing. But also when you listen, your patient could have a congested chest due to acute respiratory distress syndrome, or they could have features of pulmonary edema, which is going to affect their breathing rate and the work of breathing. All these breathing issues could be brought about either due to pulmonary edema, either due to acidosis, like we're going to see in the complications. You also notice that because of the breathing issues, the oxygen saturation is going to be lowered, like we saw in this patient. So the oxygen saturations were very low. In our circulation, as you assess your circulation, you're going to realize that your patient, the pulse could be rapid, like this patient. Your patient's pulse could be thin and thready, depending on what state the patient arrives in. They could have features of hypovolemia, or they could have features that are pushing them towards shock. So the pulse could point you into direction. Am I dealing with a low volume state patient, or do I have to maintain the volume to a certain level? Your patient could present with low BPs. Your patient could present with cold extremities. They could present when they are clammy. They could present when they are sweating. When you listen to the heart sounds, your patient could actually present with features of cardiac failure. One of the complications of malaria pushes the patient into cardiac failure, and that is anemia. So your patient will also present with pallor, and these are all things that you're going to assess as you assess your circulation. In your disability, we know in disability, we look at your GCS, we look at your blood sugar, and we look at the pupils. So in disability, they could have an altered mental state. So make sure you assess your GCS properly. And also if you look at the pupils could be unequal. When you look at your patient's blood sugar, it's very important to assess the blood sugar because this could point you towards hypoglycemia. Then you could go ahead and assess for reflexes. If your patient has features of neurological involvement, which are features of cerebral malaria, they could have absent deep tendon reflexes. And also if you assess other features, other reflexes. But this is mostly done in your secondary survey. In your primary survey, you're going to focus mainly on your GCS, your blood sugar, and your pupils. When you expose your patient could be sweating, your patient could have a fever, and the malaria fever is very classic because it presents in 3 different phases. Your patient could be either presenting in the hot stage, where the temperatures are very high, or they could be presenting in the cold stage when they have chills, or they could be presenting in the stage when they are sweating. So you have to monitor your patient to identify at what stage they are at. Also, when you expose your patient, you could have features suggestive of bleeding. So bleeding under the skin, which could be suggestive of low platelet count. And also as you expose your patient, you're looking for any other abnormalities or any other features that you could have missed in your ABCDE. So this primary survey helps you identify emergency presentation of your patient. And remember, what is going to kill your patient first will be an airway issue, followed by a breathing issue, circulation, disability, and exposure. So first things first, when your patient comes in, you want to assess, can my patient talk? Can my patient make any sounds? Are there any features of air obstruction? Is there any noisy breathing? Is the airway blocked? You want to assess your breathing. You want to assess your oxygen saturation. You want to assess your respiratory rate. You want to know, can I give oxygen or not? In your circulation, you want to assess, is my patient in shock? Do they have circulatory compromise? In disability, you're looking for any neurological abnormality, but also for any features of hypoglycemia. For our patients who have severe malaria, when you expose them, you're trying to identify if they have hyperpyrexia or if they have features of bleeding. And as you go through the ABCDE, any life-threatening issue, you stop and manage. So if you find any features of airway compromise, manage, like how this patient was managed. The patient was, a Goodell airway was inserted. If there's any respiratory distress, make sure you manage, like for this patient, the patient was put on oxygen. Circulation, if your patient is in need of IV fluids, you give IV fluids. So this is how a patient would essentially present. And this is how you do your primary survey for a patient with severe malaria.
Thank you so much, my president. Thank you so much for the emergency presentation. So, Dr. Doreen, I will given us the epidemiology and then the statistics. And you talked about complicated malaria like cerebral malaria in children. So some people are having a question like, now, why are we talking about malaria in adults? Because this is one of the conditions that we knew that malaria, we talk about children. Adult, I can get a fever, buy some Potem, and it's okay. So what is the trigger? Why are we talking about malaria in adults?
Well, like I said from the start, we are living in a malaria endemic zone. And actually, malaria cases contribute about 20% of hospital admissions all over the country. So we are seeing malaria has not gone away. We're still seeing malaria in adults, but because as adults, and most of us have grown up here, we have developed some sort of partial immunity towards malaria. So we are less likely to present in that typical kind of way because of that immunity. There are certain special groups, however, that are still prone to presenting with severe cases of malaria. So the pregnant women, the immunocompromised patients, but also our children. So most times, because the mentality is, oh, I've grown up in Uganda, I have immunity to malaria, people just take their Potem or they just take their anti-malarials and let it slide. But malaria is still rampant in the country and it can still progress according to the disease progression, like we're going to talk about the complications related to malaria. It can still progress and become severe and lead to death, even in adults. So even if it contributes to, it's the biggest cause of mortality in children, we still see high cases of deaths associated with malaria in adults. One, because most times it is misdiagnosed, but also two, there's a delay to seek care. And the other reason is that people are reluctant to go and get tested because of the mentality that, you know, I'm immune to malaria, I've had malaria before. So that's why we're focusing on adults.
Thank you so much, Dr. Doreen, for that presentation. I think we can get one or two comments from the online audience about the emergency presentation. If there isn't, then I think we shall go straight to our next presentation, and I welcome Dr. Wamala, my mentor and lecturer, to go ahead and give us the session about assessment and investigation of this patient now who we have seen in emergency.
Thank you very much, Madam Moderator. And good afternoon to you all once again. So Dr. Doreen has made my work so easy. But before I start my presentation, I would like to just make a few comments about the patient presentation. In the history, we saw that this patient had suffered severe malaria 1 year prior, and then comes in one year down the road with severe malaria, that is with so many complications. Good enough, pulls through and is discharged. So the current guidance is that when you're discharging a patient who has severe malaria, you need to follow them up monthly for at least 3 months, and you need to put them on monthly DP, that is dihydroartemisinin piperacin, our duocotoxin, monthly for at least 3 months. Oh, okay. So that is for post-severe malaria chemo prevention. That we don't want this patient to come back again with severe malaria. We never know this time when he comes back again, he may not pull through. So the plan should include chemo prevention for at least 3 months. Then you asked Dr. Doreen why we are talking about severe malaria in adults. Even adults can get severe malaria. Even adults can die of severe malaria. The parasite is continuously evolving. It is changing every day. And these days, malaria can present atypically, not the typical fevers and the headaches, which we know. So sometimes the diagnosis can really take long to be made. And by the time it is made, it is too late. So those are the few comments I had to make. So we are basically on severe malaria. We know that severe malaria is commonly caused by falciparum. However, even other parasites like Vivox, Knowlesi can cause severe malaria. Though we commonly see falciparum causing this. Next slide. So presence of malaria and any of the following complications. Those are the complications. I won't go through them, but as you remember, our patient had the convulsions, had the hypoglycemia, had severe anemia. Next slide. Was comatose. GCS was 8. Next slide. Had the renal impairment. Go back a bit. Before that. So had the renal impairment, had severe anemia, pulmonary edema, but we should be aware that it may not only be pulmonary edema, patient could be having a pneumonia as well. So you need to be open-minded. Next slide. Next slide. So like I said, even other forms of plasmodium can cause severe malaria, like Vivox. Some of the complications are the same like falciparum, but of note